maybe what we should do is what we should be doing is designing a healthcare system that is logical, that makes sense, that's efficient, and that tries to keep the most important thing a healthcare system should do is to try and keep people healthy and get them the care they need when they need it as efficiently as they can. And our system, frankly, it's not a system. We know that. It's a patchwork thing where people get their care through their employer or this or that or through private marketplace. Or if that doesn't work, maybe through a public program or a combination of those things. It's a non-system. And the reform efforts in the past have been healthcare is too expensive, so we'll try and save money. Usually it's by putting up all kinds of barriers to people getting care, so they won't use any care they don't absolutely need. We do that through insurance. We do that through prior authorizations. We do that through limited networks. We do that through copays and deductibles. We do it through 1,000 different things. And we've done a very good job of putting barriers up to the point that we have 40% plus of Minnesotans in any given year will say they either didn't get care or they delayed getting care they needed because of cost. And people going bankrupt for this. You all know all the problems. We all see it all around us. And so what Minnesota Health Plan has attempted to do is say, how do we make a healthcare system that covers everybody for all their medical needs? How do we make sure we take down the barriers to care and focus on that? And that's what the Minnesota Health Plan would be. It would be a single plan that covers all Minnesotans. It's what they call a single payer plan because there's one entity, the plan that pays all the bills. There are no co-pays, no deductibles, anything else. What does it mean? It means, well, when you sign up for a health insurance plan with a new employer, or when you sign up for Medicare, or when you sign up for something every year in the marketplace, you sign up for a healthcare plan. And that entitles you to some coverage, depending on what the plan wants, depending on the insurer, depending on everything else. And I would argue that even the quote best plans some employers offer and so on are not as good as what we ought to have. They don't cover everything they ought to cover and everything else. And my argument is also that if we just deliver that and we take out all the barriers and take all the insurance and take out all the corporate healthcare stuff in the process, we actually would find it cheaper. And to see how that measures up, the state is undertaking a $2 million plus, 2+ year analysis of our current system or non-system versus the Minnesota Health Plan and the universal care that would provide, because it really is so much more efficient. I can go into that during the discussion why, but it is more efficient. What it would do is when you are sick or whatever, need any kind of care, you go to the provider that you need the care from. If you're having trouble with hearing, you might get hearing aids. If you're having trouble with some sort of pain, you talk to your doctor. Dental care, mental health care, chemical dependency treatment, anything you need, we cover it. And do people overuse care? I'm sure they might. The insurance industry and the people who say we shouldn't do this always say, oh yeah, people already overuse healthcare. Who does? Well, they'll talk about somebody who's hypochondriac or something goes to see the doctor. There aren't that many of those folks, and there are ways you can address that. But instead of that, we put in all these barriers, as Rose Roach calls them. We call them ACOs and MCOs and IHPs and HMOs and EIEIOs, because there's so many acronyms and they're all creative things, and all of them are designed to, you get your care, but you got to go through all these hoops first, and you can the providers we choose. And it would eliminate all that because you could go to the providers you need when you need, and no copays and no deductibles. And how do they get paid? They get paid through a logical negotiated payment system. Probably instead of spending, okay, if you see a doctor and they can bill you for, they gave you this test and they ordered you to get this exam and they did this and they did this. Instead of that, it would largely be based on the training. Specialists would get more pay than family practitioners. They get more pay as they do now, maybe not as much more, but you'd probably be doing a lot more based on time. 20-minute appointment, they get so much for. A 30-minute, they might get a little bit more for. You figure it out logically. And some care types of things are more expensive because of the technology, because of the training, because of the setting it's delivered in, all those things, but you negotiate logical rates. In our system now, we have no negotiated rates, no logical anything, and the insurers who are allegedly negotiating better prices for you actually may have some weird perverse incentives to not negotiate better prices because the more they get paid, charged for things for a procedure, the more they get to keep in under their loss ratio rules. So in effect, we have a unlogical system and providers will be paid in a common sense way. We want to make sure providers are available in common useful areas. Where is the best place to deliver care to young people, especially those between 5 years old and 18 years old? Maybe 9 months of the year they're in schools together. Maybe we should have clinics in the schools, not going against education funding, but going out of the healthcare funding. Comprehensive care. Schools desperately need that, and a lot of them have that, and then they try and bill the insurance folks, and they spend so much time trying to figure out who to bill and what they can't bill a lot of them. And we want to have healthcare where it's available in a logical way. That's the goal of the system. And I could go into long details about how, but the doctors or the clinics or the hospitals would be paid by the Minnesota Health Plan. We'd all be paying into the Minnesota Health Plan. All Minnesotans would pay premiums, but instead of current healthcare premiums, which are basically based on how sick you are, the proxy for that we use is how old you are. If you're 62 years old, pre-Medicare level, you're going to be paying 3 times as much, exactly 3 times as much as a 20-year-old would. Why? Because that's the limit the federal Affordable Care Act put between the disparities based on age. But basically, we say the older you are and therefore the sicker you are, the more we charge. And the 3-to-1 ratio is reduction between the reality ratio because people in their early 60s actually are more than 3 times as expensive as young, healthy people. But we'd all be paying not based on how sick we are, but how much we can afford. We want the healthcare plan to be available to every person, affordable to all, and that's how we do it. So some people, if you're very high income, you'd be paying more, period. People who earn very little would pay something, but very little. And it's designed to be affordable to all, and so people get the care they need because one of the goals is to get people care right away. I could go into great detail on more stuff about this, but I think that's enough of an overall thing because questions can get into more detail on that. Going to turn quickly to the fact that given the current status, we don't have a study done yet. We have 23 co-authors to the Minnesota Health Plan in the Senate. Representative Liz Ryer is going to be introducing it soon, and I think she'll have House is bigger, and they'll have more authors than we do. We even have the newest Minnesota state senator who was elected in January signed on to the bill. That's a step forward. We're looking forward to, he's a very dynamic, supportive, thoughtful person. And we're moving forward, but we won't have the ability to pass it this year. The federal government wouldn't give us any of the waivers we'd need. We're trying to keep heads above water now. But as we're fighting for our budget shortfalls right now and the terrible things that are happening nationally piling on top of it, we're trying to save money and trying to deliver better care in the ways we can. And the bill, I think it's the main bill that the lobby day is focused on, is Senate File 1059, which we're calling Patient-Centered Care Bill. It would basically take our public programs, Minnesota Care and Medicaid, which cover about 1 out of every 5 Minnesotans, more than 1 out of every 5 Minnesotans. And it basically says instead of going to Medicaid or Minnesota Care and then going to the doctor and whoever and then having the state pay the bills, even though the state's paying the bills, instead the state pays the bills to Blue Cross and Health Partners and UCare until last year paid to United Health Group and Medica and others as well. We at least got the for-profit ones out last year. But we want to say that why should you get your care through an insurer when the state's paying all the bills? And I can tell you more problems with the bill number is Senate File 10. Oh, it's posted. I'm sorry. I shouldn't look at the chat. But the bill would simply replace the insurance companies in Minnesota Care and Medicaid. And it would instead have the Department of Human Services And in certain counties where they have what they call county-based purchasing, which are basically sort of local outposts for Department of Human Services, and they would pay all the bills. In the county-based purchasing, they already actually sort of negotiate rates with some, because there are areas like in dental care where the reimbursement rates are way too low. And the county-based health plans, they save money by avoiding the insurance companies. They actually use some of that money to help get more providers by raising reimbursement rates. So it's a logical system. And both the county-based purchasers, where probably, I think there are about 30, 31, 32 counties doing that now. We'd say other counties can join it too. The good news is we have Republicans who really support them, which is interesting because these are very conservative rural counties, and they're delivering health care much better and more efficiently than the health insurance plans. And frankly, they don't have the kind of network problems the insurance plans have. They don't channel you into, this is our network. They let you go to the doctor, the dentist you need to go to. They cover almost every provider in their counties. And so we need more of that. And this would simply say, in addition to that, the managed care organizations or HMOs or whatever we're calling them, those entities right now say, we manage care, we provide help to people, we coordinate care for people. And that is important. I would argue that the managed care organizations aren't really managing care. 99% of their managing is managing their claims and trying to reduce their claims payment. They're not managing your care. They're not making decisions based on your best interests. They're saying, well, you can use these providers, but not those. You have to do this first. You have to do this. We're going to do prior authorization. When you get surgery, you have to get it approved. I had back surgery a year ago. My doctor said, make sure we get the date set quickly so we can get the prior authorization taken care of. Why? My back doctor, who's a very good back doctor, a surgeon, she makes the decision with me. She talked, my wife and I, we were supposed to have 2 or more opinions, and she sounded very good to what we were saying. And I asked her, I'm supposed to, my other doctor says I should get several opinions because this is complicated stuff. And I said, what would I hear if I went to other doctors? And she told me, and I just said, I went your approach. And we went with her. But that's what we should be doing. We shouldn't have an insurance company who's never seen me, never examined me, doesn't know the details, say, well, before you try this, you got to try these things instead. That's where we waste money without getting better care. It's somebody within insurance position who's practicing medicine without a license. So our bill would say some of the things those insurers do may be truly managing care. Okay, we may coordinate this, make sure people get to their vaccines on time or other things. They may do some of that. And so we want to make sure that in our patient-centered care bill, that family practice doctors, pediatricians, folks who deal with general practice tend to be the lower paid doctors, almost always the lower paid doctors. They're doing all the coordination. A clinic that I go to should coordinate that. You or I might not have much coordination needs. Some people with mental health challenges may have very intense ones. But we want to make sure there's some of that. So we provide a bump in compensation for the clinics that are providing the primary care for us. And in the end, we think that's more efficient. It's better care. And I'll give one more argument for it when I say better care. And that is a couple of years ago, an advanced practice nurse who was dealing with OBGYN type of issues. I can't think what they call that, advanced practice nurse. But one of them who was working for one of the low-income clinics in East Metro area approached me to say that she was really upset because some of their patients who were pregnant were being denied prenatal visits at Regions Hospital. Used to be a public hospital. It's not anymore, but it's sort of the general hospital for St. Paul. And they were being denied care there for prenatal visits. Why? The doctors were told they couldn't see these patients because they were covered by Blue Cross or United Health Group or UCare or others in a fight between insurance companies because Health Partners runs Regions. They're fighting between them. So say, we're not going to see you prenatally. And this nurse practitioner was saying that a lot of her patients are very vulnerable. They have high-risk pregnancies. They should be meeting their doctors before they go to surgery and before they have the delivery, because the hospital has to cover them when they appear to deliver a baby. But they should have visits ahead of time. I was upset enough about that. I called in the health commissioner and the commissioner of human services and said, what's going on here? Why is this okay? They said they'd look into it and try and address it. I don't know that they fully addressed it, but I think it was somewhat addressed since that time. But why are we paying 100% of the cost, then having extra costs by having the health plans administer it, having them deny care, having them do things that outrageous? So I think this is definitely a way of getting better care. And it also would allow the state to do a little bit of, the last thing I'll say about the bill is we do a little bit to help make sure we're getting better care for the areas that are short. When Fairview bought out Health East a decade ago or whenever, they promised better care for people in East Metro. One of the first things they did was shut down St. Joe's Hospital, which provided mental health and substance use treatment. Why? Because we're losing money. I wrote the board and the CEO and said, why are you doing this? You promised better coverage for East Metro, and now you're taking away one of the most important hospitals they have. Well, we're losing money. I said, did you ever ask the state, could you up the reimbursement for mental health and substance use stuff? And if you need to save money to pay for that, bring down the reimbursement rates for other things like orthopedic surgery or other things that maybe are more generously paid than they need to be? No, they never pushed the state to do that. We just want to shut it down because we're losing money on it. And so we can change that. If we have a quarter of the state's population, almost a quarter of the state's population in Minnesota Care and Medicaid, we can do that. And this bill would allow us to do that. That's the general argument for why I want encourage people to support Senate File 1059. And we believe it will save money, and we believe it will give better care to people, and it will frankly help set up the infrastructure we want for Minnesota Health Plan. County-based purchasers already have it, but we're going to help them with this legislation. And the Department of Human Services would take on a lot more people. They have like 90%, I think, are currently covered by insurance companies. We would replace them and just say, this is a public program. We don't need private insurance companies interfering with the care and charging us huge amounts of money for it. And the only thing I'll say about saving money on it, because there are plenty of reasons it would, but in 2022, which was an abnormal year, but it's always the same direction. It's just this was an abnormal year. The health plans running our public programs, the private insurance companies running our public health plans, made a profit of $675 million, 2/3 of $1 billion the state paid to them to run these programs. That was their profit from it. And that's not okay. We can save that money, and that's why I'm asking for this. With that, I hope that's a real brief summary of Minnesota Health Plan and the patient-centered care bill, and I hope that explains why we're hoping to move forward on the one this year. I'm not fully optimistic of it, but we want a hearing on it, and Department of Human Services is required to come back with a plan, not a recommendations, but implementation plan for 3 different ways that we could run a direct care system without insurance companies. And when that comes back next year, we hope this is one of the 3 models they propose, and then we hope to implement it. So that's the direction we're hoping. Thank you for your attention to that, and I look forward to questions.
Well, thank you very much, Senator Marty. I know our audience has a lot of questions, and we'll get right to those, but you just explained why my patients get denied care for profits for all of those healthcare companies. So I look forward to the change. I'm going to jump right in with the questions, if that's okay. The first question, and these are all ones that were submitted by people that are viewing. The first one is, today Minnesota receives federal money to support Medicaid and premium subsidies for the ACA program MNsure. Would Minnesota still be able to collect those funds under the Minnesota Health Plan?
We would be collecting different funds, but the goal is what the waivers we'd be asking for the federal government. They always say in giving waivers under the Affordable Care Act, the waivers were required to make sure that the plan, the alternative that the state's providing covers more people. Well, we're covering everybody, so that's clearly more than not everybody. We're covering better care. We're providing much better benefits. And we are meeting the requirements that, so what we're asking for is not for more funding from the federal government for doing better care. We're saying just continue to give us our share, which means based on our low income population, based on our um, population as a whole, based on everything else, because healthcare is growing faster than inflation. We don't want to be locked in at a lower amount. We want the full level of it. And frankly, um, whether they pay them to us in insurance subsidies or reinsurance costs or whatever else, we want to make sure we get a fair shake. And people say, well, that's not going to be easy to get the federal government to do. This next 4 years, we're going to get the federal government willing to do nothing. So I acknowledge it. But frankly, um, we've gotten waivers from federal government for things before that didn't make a lot of sense. This one does, and we're counting on it, and we don't have much choice. But if we ask which is the tougher challenge, getting the federal waivers so we get our share of the money, or passing Minnesota Health Plan, passing the bill here is the biggest challenge. It's if we can pass a bill that covers everyone for all their medical needs, and we're not asking for more money from the feds, just our fair share of the money, seems to me that's a good deal for them and a good deal for us.
Thank you. Well, the next question is related, but it also hits on what you talked about at the beginning, sort of the political climate that we're in. It says the Trump administration and the budget recently passed by the US House GOP are threatening to eliminate funding for Medicaid, possibly Medicare, and cut off health research funding. If these measures are enacted, it will drastically impact how the Minnesota Health Plan and Medicaid programs are financed. For example, my son could be affected in two ways. First, he has a rare disease, and the University of Minnesota is doing research on a cure for his condition. And secondly, my son has a developmental disabilities waiver for health services. Funding for both could be jeopardized. Can you address these concerns and the future of funding for the legislation you're proposing?
Sure. I think the basic thing is you have to recognize there are two things going on here. We are hoping to keep our heads above water. I mean, as a society, I talked to an economist last week saying, how do we, the kind who do economic forecasting for things like state budgets and other things like that, how do we deal with this? Because I can tell, economists will tell you, and you've probably heard this in the news a lot, that if there are tariffs, which Trump has promised a lot of them, tariffs will tend to drive up inflation. They will tend to drive down business growth. They will tend to slow down the economy. If you talk about removing 1 million people from the country, not 11 million as Trump has promised, but 1 million people from the country and blocking new immigrants from coming in, I mean, totally freezing people in Afghanistan, others who spent months and years trying to get out safely, and our government promised them this. They've got their flights, and their flights were canceled because Trump changes. You do that, that's going to have a huge impact. If we don't take immigrants in, who's going to work in our nursing homes? Who's going to work our assisted living facilities? Who's going to work in our farm fields? Who's going to be repairing our roofs when a hailstorm? We're going to have a huge hit to the economy from that. What about laying off 1 million federal employees around the country? That's going to be a huge hit on this. I asked the economists, what happens if all these things happen at once? I said, are we at risk of a depression? Not a recession, but a depression? Well, we don't really know. We as economists make our projections based on what we know. We can tell you the trends that you do tariffs, it'll do this, you do this, it'll happen this, but doing all these things at once in unknown quantities of them all at once, could it throw the economy into a tailspin? Yes, but we don't have any way to know because we haven't had any of that things happen since the 1920s. And nobody alive now was active in public policy at that time and in economic stuff at the time. So we don't have that history of what would happen. So we are in a totally different spot. If they cut out Medicare, our state budget will be in big trouble. I mean, I'm not saying cut it out. If they cut it by 1/10 of it, just so you know, we're trying to put together a 2-year budget for the next 2 years, which we expect to be about $65 billion. Our Medicaid funding for the state for the next 2 years is about $24 billion. Our general fund budget is 65. Our total state by all funds budget is about 120 billion. But so in other words, it is basically I mean, it's a huge amount. Just the Medicaid funding is a third of our general fund budget. That's the federal share. We spend that much as well. In others, Medicaid is that huge. If they do that, we're going to be throwing people off a cliff. I mean, it's just that bad. And I don't want to sugarcoat it or anything else. I think the rural hospital, we already had, and this is rare, none of the congressional delegation of Minnesota Republicans voted against that House resolution. But we already had a letter from 5 or 10 Senate and House Republicans in Minnesota saying, please don't cut Medicaid, or if you do so, do it gently because we need the money. Frankly, our hospitals need the money. Our patients need the money. People with disabilities need the money. We need it. Please don't do this. Well, they're not listening to that. And if they do, maybe the public will rise up. I have no way of knowing, but we're just trying to keep heads above water and stop people from being pushed out of the care they need. I mean, we already have a problem. It will be 10 times as bad if this stuff happens for many people. So I don't think you can say, oh, in this climate, what are we going to do if we have less money from here? The assumption is maybe someday we'll have a rational federal government again. If we don't, I mean, I think we can't control it if we've lost our democracy. The only people who can rein in the president are either Congress Republicans, and they are not willing to, or the Supreme Court, which has not shown a willingness to. And frankly, even if the Supreme Court shows a willingness to, J.D. Vance and others have said they don't have control over the executive branch. That's a separation of powers. The U.S. Supreme Court, I mean, Andrew Jackson 200 years ago said, when Chief Justice said something that they didn't like, so let the Chief Justice enforce his own order. Who enforces court orders? Well, the court marshals, not court marshals, the court folks who administer that, they're run by the Justice Department, by Trump's people. So if he decides to just say, we're going to ignore the Constitution, we're going to do this, Supreme Court says, oh, that's avoiding Constitution, we don't care. We don't have a democracy, and we have to just hope that public opinion or business community who all of a sudden are seeing their stocks tank. I mean, we don't know. I'm not trying to say this is what's going to happen. I'm just saying that it's scary enough. We can't count on the next 4 years or next 2 years at least. There's no way we can count on not only any help from the federal government, we have to hope that people around us are not getting killed, because people will die from this. There is no doubt. So I don't mean to be grim about it, but no, I do not expect that we could implement the Minnesota health plan at this time and count on any federal money for it, because frankly, the things we're doing now, the insurance system we got now, I don't think we can count on it right now.
Thank you. The next question is about Medicare. How will Medicare supplements or Medigap be dealt with in the Minnesota health plan?
Sure. The goal we would like to have is we have 100% of people in Minnesota health plan. That would require the federal government to say, we want you to take over these things. We'll cover that. Assuming they won't do that with Medicare, what we'd be doing is saying we'd be filling the gaps, and you wouldn't need you wouldn't need anything else. We will cover all your outside care, but your first payer would be Medicare, because we're not going to cover the things they're covering. But because they have so many loopholes in it, I think the single payer movement, Representative Jayapal's bill in Washington and so on, they call it improved Medicare for all, because Medicare doesn't cover so many things it needs to cover. Basically, assuming they would not give us that, then we would just fill in all the gaps. We cover all the gaps between it, but logically speaking, it would make sense for them to cover it, but nobody would need Medicare supplements or anything else like that. And why somebody would choose Medicare Advantage then, when you have full choice of providers and we fill in all the gaps here. It would be silly for people not to jump to this, but we'd have to negotiate that with the federal government.
Well, that was the follow-up to the question, is what will happen with Medicare Advantage, and will the Minnesota health plan help those folks?
Yeah, because Medicare Advantage, the problem with it is it's a scam in that federal government, Medicare Advantage was supposed to save the federal government money. Insurance companies, we could do it better and cheaper, we'll do it. So they pass this thing to allow them to exist. Before it even takes effect, they say, hey, we need more money than you're going to pay us. So they're already paying them more than they're paying for the traditional Medicare, this thing that was going to save them money. And then they do all these wonderful things to lure people there and all the marketing. My wife and I are now over 65, and we get all the marketing from this. I saw one, I'm not sure who, United Health Group or UCare, whoever it was, nice colorful brochure. They're all colorful brochures, had pictures of members of their health plans and a little quote from the side of them. One guy was saying how, this is really great, whatever the health plan is really great. I'm a member of under whatever it's called, seniors silver sneakers, whatever it's called. He said, I'm a member of 3 health clubs. I thought that's a really good use of public money. People don't have enough health care, and he's able to choose 3 of them because it doesn't cost him anything. And I thought that's part of Medicare Advantage's cherry picking. If you're a senior and you're willing to sign up for a health plan for a health club, you're probably healthier than somebody who says, I can't go there. My health is not good enough to go to a health club. So it helps pick the healthier patients so they get less cost for what they do. And they're doing all these things at our expense because they're paid a lot more than anybody else. And then they rig the system so they're getting paid more. They make their patients sound sicker than they are. We got to drive out the Medicare Advantage thing because it was a fraud from the start, and they're ripping off the system, and there are so many things. But then the trouble is, if you're in a Medicare Advantage plan and you get cancer, and all of a sudden, oh yeah, you can get cancer treatment, but you got to go way far away. You got to do all these things. You got to do these things first. All of a sudden, they start denying you care, and then people want to go out of it and go into traditional Medicare. Well, I think if we just say we're going to cover all this stuff anyway, and we're going to let you choose who the provider is, I think a lot of people would say, well, forget that, because they know what happens with it. So I think Medicare Advantage would certainly be minimized because people would get all the care they need anyway. It wouldn't be, oh, we cover your eye care and this too. And traditional Medicare doesn't. So we have to have comprehensive benefits, and we would.
Thank you. I have a whole lot more questions, but I want to check in with our monitors to see if they have questions from the chat that we should be addressing.
Yes, Nancy, we have one. It says, under the Minnesota Health Plan, what safeguards are there that this won't create a 2-tier system where those that can afford to pay private doctors for a higher standard of care, while the majority of Minnesotans have a lower standard of care with the Minnesota Health Plan?
That's a very good question, and it's the thing that in countries where they allow a 2-tier system, you have a problem. The British system was a very good system in the past, but they starved the system of money. And if you have a lot of money, you can buy outside care. That's not a way to do it. I want to make sure the best way we can make sure you have high quality care for people is make sure we're all in the same plan. If the governor and the legislature and every business CEO in the state get the same care you get, I'll guarantee you you're going to get good care because they want good care too. The decision makers in society, people with the most money, they want good care. If the only system is that, so we don't allow supplemental plans. We're saying any covered benefit, this covers it. There's no, you can't have co-pays or other things. They can't do outside billing. They can't do anything like that. Providers in the Minnesota Health Plan would have to cover everyone for all their medical needs, and therefore everybody gets the care they need. And because of that, the reason we assure that is by making sure that those with money and power, the ones who set up the system, everybody like that, are getting the same coverage that everybody who can't afford the good stuff gets.
Thank you. The next question comes from a healthcare provider, I can tell. It's a big one. Who would administer the Minnesota Health Plan? I am certain that the state will not be able to effectively handle its administration. Without additional information, I believe that the state will end up contracting with a third-party administrator, a pharmacy benefit manager, a dental plan administrator, etc. And they're all essentially owned by the same 4 organizations: Blue Cross, United, Cigna, and Aetna. Are we essentially plugging in a system from the same broken model and players to replace a horribly corrupt broken model?
And that's what we do not want to do. And how do we do that? First of all, the board, didn't go into this in detail here, but it would be governed by a board selected by democratically elected county commissioners in various regions of states would each pick their county boards would pick somebody to the regional board, and then the regional boards would elect people here, and those elected members from the counties would be then selecting various types of medical providers to fill out the board as well. Strict conflict of interest things, everything. That's how it would be governed, how it would be administered to make sure we do that. First of all, if you are doing a strictly speaking third-party administrator, just somebody who's sending in the claims payments and reviewing them and so on, there's no risk sharing, no anything like that. We take care of that. And frankly, I don't care if we do that. We actually allow in the bill that they could do that. I happen to think having the health plan do it internally makes more sense. But if people are afraid they can't administer that, you make sure that you hire a third-party administrator. Hey, if you want competition, that's where you get the competition. If Blue Cross says we know how to deal with claims and Health Partners knows how we know how to do it, well, have them compete for it, because as long as there's no risk sharing. In other words, all they're doing is taking so-and-so patient X was treated by this thing, they got this and this and this, here's the bill we pay the bill. That's a purely clerical function that I don't care if that's done by a third-party administrator. The problem we have is our insurance companies here are not third-party administrators. Matter of fact, there was a proposal last year for a public option in Minnesota. Some advocates were calling for a public option where people who were in the private exchange, the insurance exchange, could, instead of getting their care through Health Partners or Blue Cross or UCare or United Health Group, instead of getting through them, they could get it through Minnesota Care, through Blue Cross, Health Partners, UCare, whatever. And how did it save money? It didn't. It was very, very costly. $500 million for the 100,000 people, I think it was, they were expecting to be in it. Cost a lot of money, because what we're doing is basically we're not saving any money anywhere along the way. Maybe we're paying providers a little bit less because reimbursement rates might be, which is a problem with our current system. And the rest of it is just coming from higher subsidies. The state would be putting in that extra money to make sure, instead of a silver plan, 70% paid for by the plan, 30% by you, instead of that, where everything's not covered or it's copays and deductibles and so on, make up the difference. Instead, it would be like a platinum plan, 94% or whatever Minnesota Care is. And they'd just be getting better benefits. So people who chose to get into that would get better benefits. Who wouldn't choose to? Well, because they were averaging out, they were doing it the right way in terms of funding based on income. So if you're not by age, they were taking the age out of it. So if you're 60 years old and you're averaging with a 20-year-old who wants to get in the plan, your premiums on the marketplace would be 3 times as much. Here, your premiums would be the same. And so any 60-year-old would have a huge incentive to jump into it, be a huge windfall for them. And people in their 20s might, well, this is actually a little more expensive for me. Better care, but it's more expensive. So it would clearly tilt the risk pool, which could wreck all of Minnesota Care. Anyhow, I kept asking people, some of the proponents of it were saying, oh, no, we're not using insurance in this. Oh, they're insurers in Minnesota Care, but they're only third-party administrators, no risk involved. And I thought, they don't understand Minnesota Care, because they are absolutely, they have their networks, they have their procedures on this, they have all the stuff in there, the same as any other insurance plan. And so to me, it wasn't that. But no, I have a problem with sharing the risk, because then you're paying somebody who can game the system. That's how Medicare Advantage and the PMAP, the insurer's version of Minnesota Care and Medicaid, that's how they make money. That's why some of them have been so profitable. They game the system and make the state pay more, because they act as if their patient base is sicker than it is. And there's no good way to do that without a huge bureaucracy. And even then, it's not well done. So I hope I'm sorry, my answers are fairly long, but I hope that helps. And I can follow up if somebody's saying, wait, well, you're missing something here, let me know. I'll happy to get back to it.
So people might be wondering, if we make a change like this, a lot of people are going to lose their jobs. Right now, my clinic has a whole department that all they do is prior authorizations, right? We wouldn't need prior authorizations anymore. So what happens to those folks?
Sure. A couple of things. One, yes, Minnesota Health Plan. If we implement the Minnesota Health Plan, there was a study done by the Lewin Group, which is a analysis division of United Health Group. So they're not clearly not biased in favor of single payer, but this was done about 10, 12 years ago. And they concluded there'd be about, I think it was 38,000 Minnesotans who work in insurance and billing would lose their jobs if we implemented a single payer system. 38,000, that's a lot of people. And I don't want to minimize that, but in any given month, there are about almost 4 times that many people switch jobs or leave jobs or start jobs or whatever. I mean, some retiring and some new ones starting jobs, but basically that churn in the economy is about 4 times at any month. And so that's a huge thing. It's a one-time thing. And so the health plan, the Minnesota Health Plan would propose spending, as the national Medicare for All plans do, proposing money, including money to pay for the transition for those folks. And some of them need to transition. Right now, there's a shortage of a lot of professionals and so on. Some of them would need help in transition. We provide dislocated worker benefits, retraining, et cetera. Some don't need retraining. A lot of people who are doing prior authorization work are nurses or LPNs or so on. And matter of fact, United Health Group 15 years ago, when I started working on this, the CEO of United Health Group, he was a medical doctor. McGuire, medical doctor. And I say, he doesn't need retraining. He could just go and practice medicine. We probably couldn't match his $105 million a year salary, but he could just practice without our help. And so, yes, we have to take that seriously. We have to do that. We actually have a shortage of so many professionals in this state, people who they may need some retraining, but it's a one-time bump. And the fact that your clinic wouldn't need to have all these prior authorization folks, and frankly, the insurance companies wouldn't have to have all these prior authorization folks. The fact that hospitals wouldn't need all these billing clerks. It saves so much money. And that's the whole point. It saves money and gets people care without the interference. That's a position. They do good work, I'm sure, at prior authorization. In your clinic's case, helping people get the prior authorization. In the insurer's case, trying to make it a hassle to get the prior authorization. But what does that add to the system? So right now, I think one of the things our patient-centered care bill wants to focus on, making sure people have healthcare navigators. People need help navigating healthcare system. It's complex. But if you use the term healthcare navigators in Minnesota or other states, you know what people think of? They think of the fact that the Affordable Care Act in Minnesota pays insurance people to help you navigate the purchase of health insurance. They pay them to navigate that. We don't want to have people waste anybody's time helping them navigate the health insurance system and pick which plan might be less bad for them. We want to pay people to help people navigate healthcare. And so what we want to do is the things that are hurting care or getting in the way of care, we want to remove them. And yes, that's going to cost some people their jobs, and we got to take that very seriously. And that's why my bill and also the national single payer bills all provide retraining and stuff to make sure we do that. And if they lose their job, one other thing, if they lose their jobs under this while they're looking for new jobs and so on, there's a difference from people who get laid off now. They don't lose their health
care,
which is a huge issue. Anyway, enough about that. Go ahead.
Okay, this is from someone who's obviously read your book. It says, according to the book, Healing Healthcare, page 100, nursing home care is not covered under the Minnesota Health Plan unless one is destitute and qualifies for medical assistance. How is this a comprehensive plan when nursing home care leaves all but the destitute having to pay for it out of their savings or estates?
Sure, that's a misunderstanding what it's trying to do, because what I hope is clear in the book is that what we would cover, and in the bill, I think it is clear, that we'd cover all the medical care. I would gladly cover all the other stuff, but we have a problem here. My folks were in assisted living in Minnesota, and they're a very nice facility. And assisted living sometimes starts with independent, then assisted, then more intensive care, and so on. Nice facility, lots of extra things that they were fortunate to have. But, you know, are we going to say that somebody who's living at home and they're elderly and they're in poor health and say, why don't you just move to this nice condo or this apartment type of thing where they're going to give you assisted care, you're going to get your care there, and you can get rid of your house, save all the money and everything else. We're not trying to make a housing thing. We have to acknowledge they're intertwined together. So the Minnesota Health Plan would pay all medical costs related to assisted living or nursing home care and so on. It would not cover the housing costs. But then you got to recognize there are some people who right now, when they move into a nursing home, they're on Medicaid because they have nothing left. They have no money left. And so so we would say the only means tested thing in the entire bill, the only means tested service in the Minnesota Health Plan would be the housing and room and board kind of costs of that for people who are whether if they're destitute, which you really are on Medicaid, we'd cover it for them. But for everybody else, it's kind of, you're choosing to live there. Maybe you'd be better off living at home, might be a lot cheaper, might be everything else. If we can provide the same level of care, it just wouldn't work otherwise. I hope that's clear to the person. If they're still questioning that, want more clarification, I'm glad to follow up. But I hope that's a good illustration. We cover all the medical costs of nursing homes and long-term care. The only thing in the entire bill that's means tested would be the room and board for low-income people in nursing homes or assisted care.
Great, thank you. Here's one. Many people, especially Republicans, do not believe that the government can deliver a health system that is better than the private sector. How can that be overcome? Can I say just wait a few months? Because
that's the trouble. I mean, I keep thinking, I'm afraid things are just falling apart. I'm afraid they're just falling apart on us, but I don't want people to suffer in order to see how bad the system is.
Right.
Anybody who says we've got a great healthcare system hasn't struggled to get care, hasn't had to fight off and be denied care that they should get, hasn't gone into medical debt, hasn't done anything else. And there are a lot of people who it's been fine for because they're now having to wait longer and longer and longer. They're getting more and more hassles on how they do it. It's just nuts. But the system is falling apart. And does that mean government can run it better? Well, frankly, a lot of things have run very well in the government. Social Security is a very simple one that covers everyone and does it well. Frankly, Medicaid and Medicare, until they were privatized, were done much better and much more efficiently and much cheaper. Private sector gummed up the works very greatly and so on. But yeah, I mean, to me, when they say, how can the government run this? Okay, well, one, the government's not running this. Right now, the people who are running your healthcare right now in the current system are insurance companies and employers and government. They're telling you what care you get, how you get, and everything else, even which providers you go to and what you're not going to get coverage for. In the Minnesota Health Plan, it's a medical professional and patient relationship. The doctor and patient make the decision. This is the appropriate care. You don't have the insurance company. You don't have the employer. You don't have the government telling you how you get the care. Who's administering it? If it's too hard for Minnesota Health Plan to pay the claims and everything, which it's not, the government has done that very well in the past. It's only when we make it so convoluted where fraud occurs, that's under the current system where that all happens. You avoid that if you have a very simple payment system. Hospitals, how do we run elementary schools? Hospitals, you don't need billing clerks. You don't need collect co-payments and deductibles. Every kid gets to go. And how do we fund the schools? The school boards give the school a global budget. Here's how much you have. Here's how many teachers you get to have and everything else based on the need. We want to have hospitals the same way. The board negotiates in this community. Here's what the need is, how many beds they need for this and so on. And if the hospital has all of a sudden an epidemic of some sort, they have higher costs. You renegotiate in the middle of the year to give them more. but you work at that, and so you don't need all the billing clerks. Then somebody goes in and they're qualified because they're a Minnesotan, they're covered there. You don't have to keep track of how many pills they get or how many units of oxygen they get or anything else. You still need a lot of medical charting just to track where the patient is. But most of the medical charting we do now is for billing purposes, period. We save all that. We get better care for people that way. And for people who say government can't do it, this is not a government-run healthcare system. This is a doctor and patient-run healthcare system.
Thank you. Okay, I have another one that I could comment on as a healthcare provider. We often hear that in other countries where the government is responsible for healthcare, people have to wait a very long time to be treated. Is that true? How will the Minnesota Health Plan be different?
Sure.
And I'm just going to say I had to wait 7 months to see a doctor recently, so we're there.
I think I heard this question a lot more 10 years ago. A lot more because in Canada, you had some waiting periods. You don't have waiting periods if you're having a heart attack. You have waiting periods if you want to schedule knee surgery or something that's not urgent. And that's logical. Canada has too long of waiting times. They have an advocacy group that's fighting against it. And the folks in it who are fighting against the problem are saying the problem isn't that it's a single payer universal healthcare system. The problem is we're not funding it appropriately. That happens. There's no logical connection between universal health care and waiting times. There's a real connection between inadequate payments and inadequate providers and so on. And our country is getting far worse very quickly. I would make two arguments where it would do something about it. First of all, the bill had one of the legal principles that would be behind the bill is they have to make sure care is available on a timely basis. And I think timely should be a lot less long awaits than people wait now. But we're at the stage now where we don't have enough providers and all the gummed up work. We want to make sure it's as efficient as possible. And we can do that by getting rid of things where you have a clinic has to have people trying to fight for prior authorization. I've talked to doctors who spent as many as 6 or 8 hours of their own time fighting over months to get prior authorization for a patient. That's a huge waste of time. So we'd have more people there. I think you can talk to any of you who are nurses can talk about the fact how many nurses we have in Minnesota. We have a shortage in hospitals, not because we have a shortage in nurses, but because so many nurses say, I'm not going to practice anymore. There's too much stress. They underpay us. They overwork us. They short staff us, which makes our jobs more dangerous. You treat the employees decently. You give people a system where they're not spending all their time checking boxes and filling out forms and treating patients. All of a sudden, I think you'd have a lot more nurses saying, I'm going back in the field. And the doctors, I think a lot more of them might decide they're not going to retire as quickly. And you'd have some of those doctors who are doing other medical billing related things saying, oh, we don't have jobs in this anymore. I'm going to go back and practice medicine. So I think we would do that, but the bill requires the plan to ensure that. How would they do that? They might have to provide more funding to certain medical schools or nursing schools or chiropractic colleges, whatever, make sure there are enough providers to address the need. But again, bringing down waiting times. 10 years ago, it wasn't a problem, but now, yeah, last time I saw my back doctor, which takes about 6 months to get, she said, because it was before the surgery and so on, she said, set up another appointment for 6 months from now. I said, what if I don't need it? Oh, set it up. You can always cancel it. And it takes you 6 months to get one anyway. And I mean, that's a stupid waste of everybody's time, but that's how long it's waiting. And any one of us, I mean, getting a primary care visit nowadays at Health Partners, right? It takes a long time and it's getting worse fast. So anyone who says single payer is a cause of that, no. The cause of it is inadequate funding and making the system so providers don't want to do that work.
Exactly. Well, I want to check in with our monitors just to see if there are questions from the chat that I'm missing.
Yeah, Nancy, there's a few here. I know we're running low on time, but there's probably some quick ones. Wouldn't the increase in healthcare demand help absorb the people who would lose their jobs?
Oh, absolutely. I don't have any fear that people will lose their job. I mean, we need so many more professionals in healthcare. We need so many more professionals in so many other areas and people who are skilled enough to figure out the things for prior authorization and so on. They can do other work as well. And yes, there will not be a trouble getting jobs. This state is still in the, like nationally, everybody's still, we got to do this to create jobs, to create jobs. What I hear from employers is, get us workers, get us workers. Schools can't find enough teachers. Hospitals can't find enough doctors. Everybody's struggling across the board for this. We don't need people occupied and paid very well to make it harder for people to get health care.
And another one, Nancy, have surveys been done in Minnesota to find out the level of support for this? I would think that some rural areas would have some interest.
I think one of the illustrations, first of all, I think the polls have consistently shown that the idea, if you frame it government-run healthcare, oh yeah, no, I don't like government-run healthcare. You frame it where you have a system describe the system honestly. There's been usually 60+% supporting a single payer system. I wouldn't use the word single payer even. Most people don't know what it is. I mean, it's kind of, what kind of car did you buy? Oh, dealer financed. What kind of car though? A dealer financed. I mean, that doesn't tell you anything. So the honest polls about this, they're fairly consistently shown. I've never seen any that's not at least a plurality supporting, but usually it's around 60%, 55 to I think 60 some percent who support it. So I think there's the support out there. The other thing is, like, when we're talking at the Capitol here about the cuts in Medicaid and everybody, well, this is going to hurt this many patients, this many people, they're going to lose their care. Well, it's not just the patients, it's also the medical providers, the mental health clinics they're going to shut down, the hospitals that can't afford to do it. In greater Minnesota, the only way we have hospitals open is if we have a fair system for it. Because the hospitals in greater Minnesota aren't closing down because there's no need for the care. Mayo Clinic shut down the Fairmont Hospital about 10 years ago or so. They almost shut down the entire Albert Lee Hospital. Why? Not because there was less need in those communities, but it didn't fit in their business model. We want a system that works like this. So yeah, there's plenty of need for people and plenty of support for them when they see what it is. But right now, I don't want people to see how bad our system can get and then say, well, maybe we should fix it. I think we should fix it now.
And maybe we can squeeze in one more, Nancy. What do you think?
Go for it.
No?
Yeah, go for it.
Okay. Could you please elaborate on aspects of the county-based purchasing that is similar to how the MHP proposal works?
Sure.
Ooh, this doesn't sound like a quick one.
No, it's okay. It's okay. I'll try and be as quick as I can. County-based purchasing, unfortunately, for some reason, Department of Human Service doesn't seem to like it. They think these are health insurance plans, and they want them to compete with health insurance plans, and they're making them compete with health insurance plans because they say the federal government requires, if we're going to have an insurance-based system, they have to have at least 2 plans available in any county and so on. And so what they're doing is these counties who don't have a choice. I mean, if a patient isn't getting cared for elsewhere and they go into mental health crisis or something else, the counties are the one who pick up the tabs. They can't get out of it. And so they're providing this, they can't dump them. But then a few years ago, Medica came in and said, oh, the state was having this competitive pricing bid war. And Medica came in and undercut UCare, which was covering much of the state. UCare laid off half their employees, lost 9/10, I don't know, they lost the majority of their customers. And Medica came in, and all these people in UCare plans had to switch to Medica. And then a year later, Medica decided, we're losing money on this. So they dropped out of this, and hundreds of thousands of people had to switch plans. And when you have those plans competing with the county-based purchasing ones, county-based purchasers aren't spending any money on marketing. They're taking the people who are there, and they're now competing against companies coming in and saying, hey, we're going to give you all these extra benefits and glossy pictures about how nice this is going to be. And so the state has always treated them very poorly, not what they were supposed to be. But basically, the county-based purchasers are given money by the state to take care of the patients, and they take care of the patients. It's basically like a mini single payer in those counties, and there are groups of counties. Only one is in a single county. The rest are all groups of counties, and you're covered by them. It's a single payer type of arrangement, and that's how it works. And they've been more efficient. They've been doing better care. And a lot of them, you talk to patients out there, other health plans say, oh, yeah, we've got adequate network of mental health providers. And you call through the entire list, and not a single one is actually in the network and taking new patients. Find a dentist in a lot of those counties is impossible, but some of those counties with the county-based purchasing system, they have more dentists. Why? They talk with the dentists, they negotiate with them, they actually give them extra reimbursement out of their other savings. It works very well, and I'd see them as kind of like what we want, only on a statewide basis. And I don't mind more local administration. Minnesota Health Plan can send it to the counties if they want. What we want is people who are delivering healthcare in a logical way and paying for it in a logical way, and not somebody who's trying to profit off of it. Because the counties, they can't profit. It's the government. Anything they don't cover, they cover with tax dollars, and so they're not in it to make money. And I know that nonprofits are, quote, not profit making, and they don't. But as I told you earlier, they made 2/3 of $1 billion in earnings, not profits technically, a few years ago because of the nature of the thing. They never have a loss. They're not going to allow them to have a loss. So they always make money off us. And so I think it's a really excellent example. And I keep thinking they don't tell people you can't get this care you need, this mental health care, because if we don't treat you for that, we're going to pay down the road. Well, down the road meaning next week, we're going to pay more costs because you've had a crisis. The health plans have the incentive to deny care, and they do. So I hope that helps. Anything else?
Oh, we have so many more questions, but we are running out of time. I do want us to be able to get to talking about Lobby Day, but I'm going to squeeze in one last question. What's the best way to educate our legislators about the cost savings and benefits of this plan?
Good question. I think HCAM, Healthcare for All Minnesota, has been doing all kinds of things, even seminars lately and so on, meeting with new legislators. And I think that's what we have to do. Right now, unfortunately, given the politics of the times, I don't expect, I mean, we had a vote in committee about 15 years ago when I first introduced Minnesota Health Plan. Chairing the health committee, had a hearing on it. One of the Republicans voted for it and stunned his colleagues, but he said, you know, what we're doing isn't working. This seems to be a better option. And unfortunately, the Republicans beat up on him, and he told me a few months later he could never vote for it again. And they ran a candidate against him in the primary and defeated him. So I don't expect any Republicans to pick up. We actually had one co-author for our patient-centered care bill, and I just noticed today that he had withdrawn his name from it as a co-author. I'm sure he got the same pressure. Why are you supporting this? I mean, this is not a partisan issue. And the county-based purchasing things, there would have been one in southeastern Minnesota, Steadfast for Olmsted County and the surrounding counties, Mayo Clinic-centered area. There were about 6 or 9 counties, and legislators, most of whom were Republican, not all, but most were Republican back then. They spent time setting up this plan, and they got buy-in from all the legislators and everything else. They had done all the research, $1 million of analysis, how to set it up. And Governor Plenty shocked everybody. Health plans wanted him to, and he vetoed the bill. And they just gave up. They just spent so much time and effort and were blindsided by it. But otherwise, you talk to the legislators representing those county-based purchasers. Oh, that's not government healthcare. That's good stuff. And they like it, and that's what we have to get to. And I started this call by saying how grim our times are, and I don't want to sugarcoat that at all. And I'm scared about the way things are. But what you're doing, what Indivisible is doing, what Healthcare for All Minnesotans doing, what we're trying to do is what we have to do for each other to give each other hope. Because if we quit fighting, I'll guarantee you we lose. If we keep fighting, we're going to win. We've won many battles in the past. We can win this one. But nothing more important than taking care of our health.
Well, thank you so much. I want to shift gears because we have just a few minutes left, and I want to talk about Lobby Day. And we have one more surprise. We know that Rose Roach is in the audience tonight, and we'd like to ask her to say a few words about Healthcare Lobby Day. Can we unmute Rose so she
I'm
can?
unmuted.
Awesome.
Great. Thank you, Nancy. And thanks everyone for having me. It is always a pleasure to be side by side with my single payer soulmate, Senator John Marty, and when meeting with everyone and talking about healthcare justice. So the patient-centered care bill that Senator Marty just talked about is about structural systemic change. It's an important step in building the public health infrastructure as we create the conditions that are necessary to implement the Minnesota Health Plan. But another important step, as I'm talking about Lobby Day here, I want to add a couple of other ideas that we're going to be lobbying about, a couple other bills. Another important step in building that public health structure is how the state pays for prescription drugs. It's time we move away from the costly HMOs and pharmacy benefit managers, or PBMs as they're known, when it comes to accessing affordable prescription drugs in our public health programs. That's why Representative Liebling's state prescription drug purchasing bill, which is numbered HF 1093, is also an important bill for us to urge legislators to support and pass. There are currently two middlemen between the Department of Human Services and pharmacists, HMOs and the PBMs that the HMOs contract with. The HMOs contract with the PBMs supposedly to negotiate drug prices with the drug manufacturers. The state currently runs about 15% of the medical assistance program, and the pharmacy benefit managers run the rest of it. So the state pays pharmacies about $10.17 a prescription, whereas the PBMs only pay them 10 cents. So you can see what this is having, how this is having a horrible effect on our independent pharmacies, which are going by the wayside thanks to the CVSs and Walgreens and Optum RXs of the world, and thereby it is stressing patients who need these medications to survive. So in place of the PBMs, the Department of Human Services Commissioner under this bill would administer and oversee a prescription drug purchasing program for medical assistance and Minnesota Care enrollees that will provide a fair reimbursement rate for all participating pharmacies, and especially helping out our independent pharmacies to stay in business. Eventually, the program could benefit all Minnesotans by negotiating for lower prices for all and allowing self-insured employers, private health plans, and individuals to get their prescriptions through this program. This is another important step towards a sane, patient-provider-centered system. And while structural systemic change is critical, so is harm mitigation. We must help people now. Thanks to Attorney General Ellison working with Senator Bolden and Representative Reier in the 2024 legislative session, Minnesota has made significant changes to help individuals and families deal with medical debt, something that should not exist as a thing. Those changes included the prohibition of medical debt being transferred to a surviving spouse. Medical debt will no longer be reported on credit reports, and it lowered the percent that can be garnished or taken from bank accounts or wages to pay medical debt. Medical bills are the leading cause of personal bankruptcy in the U.S. and hits the middle class the most. Although over 90% of Americans have health insurance, 54% carry or have carried medical debt within the last 5 years. Fear of medical debt causes people to defer or skip medical care, which can lead to worse and more costly health outcomes. That's why this session, Attorney General Ellison, working again with Senator Bolden and Representative Reier, have introduced legislation, SF 1349 and HF 1158, that will appropriate $5 million for a debt forgiveness nonprofit organization known as Undo Medical Debt to buy and forgive an estimated, get this, $500 million in medical debt for roughly 250 to 400,000 Minnesotans. So important legislation for us to consider. And if any of this excites you, and you're ready to pitch in and help us make it happen, then I have a really important invitation for you. On March 10th, we're heading to the Capitol for Healthcare Lobby Day. It's an important opportunity for you to make your voice heard and fight for a healthcare system that works for everyone. Lobby Day is your chance to meet directly with lawmakers, connect with other advocates, and be part of the movement that is pushing for a better healthcare system here in Minnesota. If you don't have any experience doing this, no problem. We're going to provide training opportunities on March 6th, March 8th, and we're even going to do it the morning of the lobby day itself. We're going to give you talking points, and we're going to make sure that you feel confident and comfortable going into your meetings with your legislators. We need you to show up and help us build momentum for real healthcare reform. Whether you've been in this fight for years or you're just getting started, your presence makes a difference. So will you join us? Click the link that has been put in the chat multiple times by Sandra. Thank you for doing that. Or visit Healthcare for All's website at hca-mn.org to sign up. And please do join us and take action. Let's take action together on March 10th. And I'm hoping to see you all at the Capitol. Thank you so much.
Rose, hang on, stay there for a minute. And I just want to say thank you so much, Senator Marty. We know that you have to leave off to another meeting, which is, why you've been reelected 12 times, right? Most hardworking senator there is. Thank you so much for spending this evening with us. And Rose, you just did basically my call to action. We always end our events with a call to action. And my ask of everyone that's here tonight is that they would sign up for Lobby Day. And I was going to ask you to talk a little bit about whether there was a cheat sheet or a training, and you just covered it. You amaze me. You don't even breathe. You just keep going.
I want to stay within my time frame.
You did great. The link is there. We're also going to send out a follow-up to folks. So, the information will be there to sign up for Lobby Day. And it sounds like when they sign up, they can get some training.
Yes, you'll get information, a follow-up email that'll give you an opportunity to sign up for the trainings if you're available. If you're not, please don't let that, discourage you at all, because I'm telling you, it's not that tough. We're going to give you a single sheet of paper. You're going to go with other people. You're going to have your talking points. And honestly, if you get asked a question that you can't answer, here's what you say to them. I don't know the answer to that, but I know people who do. So I'm going to put that down on my sheet of paper, and Healthcare for All Minnesota and PNHP will be following up with you within the next couple of weeks to get you the answer to your question. You do not have to know it all to be someone that is trying to move your legislators to actually implement a sane healthcare system.
Absolutely. We're the constituents. We get to ask for what we need, and
That's
we
right.
don't have to be elaborate about it. We don't have to be healthcare professionals to ask for it. And we'll all be there. So we'll be doing this together. So please, everybody, sign up for Lobby Day. Well, thank you so much, Rose. So appreciate you. So appreciate Senator Marty. And appreciate all of you who took the time to join us tonight. Thank you, thank you, thank you. We'll see you on Lobby Day. And this will conclude our session. Good night, all.